Hello, everyone. This is Dr. Andrew Heyman. I am the Director of Integrative Medicine for the George Washington University, and I am speaking to you on behalf of Da Vinci Labs' new professional education series. I'm delighted to be a part of this project. We have assembled a new learning curriculum that I believe will expand your knowledge base and give you good practical clinical information to ensure that you have excellent patient outcomes. With that being said, today's subject is the therapeutic relationship and communication skills. This is an incredibly important topic that I think sometimes is often overlooked in generating a adequate skill set for practitioners. And this has to do with our ability to understand our patients, what their needs are, and oftentimes their hidden agenda. What can we do to facilitate healthy behavior change and sustain those changes over time? This really is an application of our empathy and compassion, our ability to listen and reflect back to the patient in ways that is helpful and meaningful to them. And this is a skill set. It's something that can be learned over time. I think many of us are probably naturally gifted and good at this process. Some of you may have had formal training in this approach, and others, this could be new information for you, but it may feel familiar regardless. My sense is that many practitioners in the field of integrative and functional medicine are drawn to this style of practice because we really do want to connect with our patients and help them grow and heal in their own lives and become a fuller person in their own right. So this process is something that we can frame for you, give you tools and strategies to build the therapeutic relationship and ensure good clinical success regardless of the tools and therapies that you may bring to bear. So we felt at Da Vinci it was important to start with this notion of relating to patients first, and then through a series of other lectures, delve into the details of specific clinical strategies. So the objectives for today will be reviewing the Macy model of the practitioner-patient encounter. We'll apply concepts of communication skills to engage patients and enhance the quality of that relationship. We'll help you synthesize knowledge of effective listening and empathy and trust in the therapeutic relationship and learn to sustain healthy behaviors over time. The single biggest problem in communication is the illusion that it's taken place. And I think this is really true that in an expert-based model where we're expected as practitioners to have all of the information, all of the answers, oftentimes we're providing an avalanche of solutions to patients. We're giving them as much knowledge as we can, but that's often all in one direction. And to construct an adequate therapeutic relationship, it really is important to have an exchange of information, an exchange of ideas, and to really assess where is the patient at and how do I effectively communicate with them in a way that they can understand. So this illusion that we've communicated because we've given patients lots of information is really pervasive, especially in our field, where not only I think are we early adopters, but we really are also what I would call information junkies, that we rely on lots of extended information about our patients. We delve into areas of functionality in their physiology, nutrients and hormone balance, exposures and toxins, even now genetics. And while we can be excited about all of these concepts and ideas, I think it could potentially be overwhelming for patients. So as I said, I think we all have intuitive communication skills in this field to some degree. I think that's one of the features that attracts us to this style of practice. And my sense is most of you are likely very good as intuitive communicators, and that this genuine interest that you have in your patients is felt by your patients. And your attention allows you to read your patients well and respond appropriately. I think many of us probably do this naturally. And it all comes from this internal observer, this mindfulness that we bring to bear that allows us to monitor the communication that we have with patients, assess whether or not we feel like we're being effective in that regard, and paying attention to the technique of building the therapeutic relationship will help improve your communication skills as well as the relationship overall with patients. And there are tremendous benefits to this that improve patient health through improved relationships and more effective participation in care is well known. It's grounded in the evidence that the more engaged the patient is, the more they feel empowered by the process of care, the better clinical outcomes they have, regardless of the diagnosis. And that we know that by establishing a good relationship will improve trust, and that actually in turn enhances disclosure by patients. You in fact get more information from them the more they trust you, and that allows you to make better decisions. You can also create patient empowerment and return a sense of control and agency to patients, even if they have serious medical issues, that by virtue of collaborating with the patient, discussing options, giving them choices, supporting them in that approach, and ensuring that they feel empowered throughout the experience, improves their sense of self-efficacy. This in turn also helps with diagnostic accuracy and patient safety because they're often willing to divulge more information about what's going on with them and also reveal what we call the hidden agenda. Why are patients really there? What are they trying to get out of this process with you? And sometimes it's not clear that their goals are in alignment with their physical condition or even an aspiration for cure. Sometimes you might be surprised at why they're seeking care from you and what they're hoping to get out of the process. We know overall that this approach improves patient satisfaction and decreases malpractice risk. I think that not only does it allow us to enhance the care process, but it also limits your legal exposure. Patients are far less willing to bring a lawsuit if they like you, if they trust you, if they know that you're trying to be empathic. And also, this orientation towards the patient is very satisfying to practitioners, and it allows us to decrease physician burnout and improve physician satisfaction. I think this is key in this process because what we do in integrative, functional, and anti-aging medicine is complicated, and it continues to get more and more complicated as we learn ever greater amounts of information about how the body works and multiple ways that we can intervene using our integrative strategies. But that's not always easy. The bar is often high. Patients are not only complicated, but they usually have significant acuity and morbidity. And so we need to make sure that we protect ourselves in the process of caring for patients. So what's the patient's view of the medical encounter? The doctor will be in shortly to type on the computer and update your chart. If he has time, he will ask how you're feeling and take a look at your rash. And I think, you know, we're so consumed by this process of information management that we can somehow lose the relationship with the patient itself. So what are some barriers to good communication? I think, you know, you all can fill this out better than me. Most practitioners will say the number 1, 2, and 3 reason is lack of time. This is the most common complaint by far, but I think equally as important, maybe more so, is the low self-awareness of our internal state, which we don't always focus on. And that is to say, what is your own physical or emotional condition that affects how you're relating and communicating with your patients? Are you tired, hungry, sad, anxious, distracted for other reasons? What are your own judgments and biases as you enter into this relationship? And if you don't monitor for these factors, it can become an unconscious impediment to success. So we need to focus on the self-monitoring process to enhance our communication skills. How do we do this? Well, we focus on meta-communication, listening, questioning, responding, empathy, and a structured approach to the interview process that we call the Macy model that is evidence-based. So nonverbal communication is so important in this process. So what's the message are you trying to send to the patient? Am I here 100%, or am I busy thinking about other things and other patients? If there's a conflict between your nonverbal and spoken messages, the nonverbal message is the one that'll be believed. Patients are very good on picking up what you're thinking and feeling as opposed to what you're saying to them. And if they're discordant, if you're not really fully in the room, as it were, and you're distracted, you have a high emotional tone yourself, you're not fully present for that patient, they will know. So when the eyes say one thing and the tongue another, a practice man relies on the language of the first. So you can unconsciously project your own emotional state via nonverbal communication as well. We need to be very careful of that. So how do we do this? Well, we can suggest that we're caring and we want to listen to the patient through all sorts of nonverbal cueing. So open and closed body posture, sitting versus standing, leaning forward versus back, tone and volume of the voice, encouraging sounds, eye contact, facial expression, interpersonal distance, and touch. For facial expression and body posture, it can be difficult to accurately assess what is going on inside of the patient just by facial expression itself. I have a link to a quiz that you can take in this regard, but we don't just depend on one factor. We need to look at the total in terms of all the information that's coming off the patient, and we need to monitor how we're feeling in that regard. So body posture and language has many constant factors that can be influenced by personal idiosyncrasies, cultural factors, and social situation, or even species. So did you know that when a cat wags its tail, it means something completely different? And that can be true, that sometimes the physical cueing that we see with patients might not be indicating what we think, so we need to be careful in that regard. With respect to questioning, there's a variety of types of questions that we can ask patients to elicit information that gives us a context and a background and orientation to create an atmosphere of curiosity and inquiry that patients either feel engaged with or they can feel excluded from. And so we have this range of types of questions, basically open versus closed. So open questions are less directive, and they allow the patient to formulate the context and the answer. Open questions start with the who, what, where, when, and why, and how. They cannot be answered with a simple yes or no, and they facilitate a more open, elaborate, patient-centered response. I always initiate conversation with patients using open-ended questions. I want them to talk. I want them to feel comfortable just having their time and their space to tell me their story, because stories are very powerful. And closed questions, though, are very different, and they serve a purpose as well. It's not that they're necessarily bad. They also just have to be used strategically. So closed questions exist along a range, from closed to very closed. For example, any health problems to have. You ever had a heart attack? Good for factual queries. Avoid leading closed questions. You don't smoke anymore, do you? This form of question tells the patient what the right answer is and makes it hard for them to tell you anything different. So here are some other examples. Very open. How you been doing? An open question might be, what kinds of symptoms are you experiencing? So now you're narrowing it down to health related. Moderately open. What about using acupuncture to treat this pain? Moderately closed. From the three options we discussed, which do you want to do? That can be a very powerful technique to narrow within choices. Highly closed. Would you rather use this curcumin product or that one? You know, really forcing a discussion on a specific topic. And then finally, totally closed and leading. You haven't had any chest pain, have you? So we need to be careful of the totally closed, but we can use the others very strategically to elicit information in the patient. We also, therefore, as we're going through the process of inquiry, have active listening. So once you offer an open-ended question, you allow them to speak without interrupting, and you want to demonstrate an interest, meaning you have this active posture, essentially, towards the patient. So you're leaning forward, you have good eye contact, you're making encouraging gestures and facial expression. And you want to attend to the verbal and nonverbal cues of the patient. And your compassionate attention is a very powerful therapeutic tool. So this notion that you're conveying with the tone of your voice, your facial expressions, your body posture, that you care, that you're present, that you're listening. And of course, if there are things that are going on inside of you that potentially get in the way of a successful conveyance of active listening, the patients will pick up on it. So this self-monitoring process that I talked about is so critically important to gauge, what is my emotional stance? How am I reacting to the patient? What am I bringing to the table? So listening to the patient's expertise. You have to learn about thousands and thousands of diseases, but I only have to focus on fixing what's wrong with me. Now, which one of us do you think is the expert? And so I really am a big believer that the better we get at listening to patients, the more attuned we'll be to some of the subtle pieces of information that they'll convey to us. And oftentimes they'll tell you what's wrong with them. But this notion of active listening is so key to that process. But patients are living in their bodies, and if we just trust them and really honor what they're saying, and they'll display the pattern of illness that sometimes unlocks the key to the diagnosis. I find more and more often I'm not using as many objective labs. I use those only to maybe confirm what I think and what my suspicion is, because patients can be so good at this process. Most people do not listen with the intent to understand. They listen with the intent to reply. And again, we're getting back to that notion of practitioner as expert as opposed to practitioner as facilitator. And so listening is really key to that process of transitioning into that sort of compassionate, active listening, empathic approach to the individual. And we try and give them the things that they need to feel whole in their lives. To do this, we want to limit distractions, meaning listening is attending to your own internal process instead of the patient, waiting for your turn to talk, avoiding interruptions. You want to make sure we have privacy. You don't want to pay too much attention to note-taking, basically showing that you're really present. And then responding. This is so important that once you've collected information and you've demonstrated your ability to be present and to listen, you want to be able to provide reassurance and give permission, directly or indirectly, for patients to continue to disclose, and also clarify content of previous communication. These main skills of reflection, confirmation, empathy, and clarification are central to this process. I often reflect back to the patient, repeat what they say, get their confirmation and reassurance that I'm really listening, I'm remembering what their story is, and I'm showing that I can state it back to them, and that they can use that as an opportunity to even correct me. This echoing or reflecting the patient's words, emotions, or behaviors is really a powerful tool. So you've tried 3 things. Go on. You look upset as you're telling me this. That is a really critical thing to do if you don't employ that strategy in your conversations with patients. That you're tuning in to their emotional state. And it might be one thing that they're telling a story, but if they get tearful, it's really a nice time to stop and say, I can see that you're upset right now. What is it about this moment? What is it about this part of your story that's so upsetting to you? I noticed that you get a sad look on your face when you talk about your son. Patients are so appreciative when you use this technique, and it often encourages them to continue the disclosure because they feel reassured by the fact that you're actually caring and tuning into them. Now, you were talking to your husband, and then what happened? So all of these are really good strategies to begin to cement that bond with the patient. You can do things like begin with a disclaimer, just to be sure I heard you correctly. Not just to be sure you were clear. The onus is on you, not the patient. Then restate what you heard, so the patient says as they close, as close to their words as you can. So if you summarize, try to maintain their emphasis and meaning. When you're clarifying something, again, start with the disclaimer using ownership language. Okay, I'd like to get the timeline straight in my head if you don't mind. Would you go over it again? First, this happened and that happened. A real title of a communication lecture, can you spot the problems? Did they get it? Strategies for making sure patients and families understand your message. So I think again, as experts, we spend so much time wanting to have the right answer, and that makes us feel good. But having these tools at our disposal of pausing, reflecting back to the patient, asking for clarification and confirmation, using I language, restating what they've offered to us, and showing that you can summarize and that you really get what they're trying to say. And all of this is about empathy to some degree, which is seeing with the eyes of another, listening with the ears of another, and feeling with the heart of another. So this notion that you're connected in to the patient. From the evidence-based point of view, it's a cognitive attribute, which involves an understanding of the inner experiences and perspectives of the patient as a separate individual combined with the capability to communicate this understanding to the patient. Empathy declines among medical students and residents as their training progresses, and empathy addresses emotion in the interview and allows you to demonstrate that you do know how the patient feels. Again, you look really sad when you talk about your son. Could you tell me a bit more about that? It's not about the diagnosis. It's not about the physical condition. It's the context in which that story is happening. Empathy is different than sympathy. So empathy is feeling with. It's intellectual and emotional understanding the other person's view. We don't have to agree. You just need to understand it from their perspective. And you don't need to have had the same or similar experience to demonstrate a level of empathy. Sympathy, on the other hand, also has its role, but a less of a role. So it's feeling sorry for, it's fellow feeling, there's no real shared perspective, and there can even be pseudo-sympathy, so the easy apology. Sorry your paperwork isn't here, sorry I don't have your size. Now, we do give statements of apology, we do show some sympathy, but the bulk of our emotional tone is really oriented towards empathy. What is it not? Well, it's not judging. So we don't want to let our unconscious biases or judgments that are often expressed directly or indirectly interfere with quality communication. We don't want to do just advice giving. We're addicted advice givers. There's a time and place for this, but that's not empathy. Quizzing, so asking questions for clarification can be good, but it can often feel a little too pointed to the patient and even make them defensive. And then finally, placating. So facile platitudes that amount to kind of patting them on the head, saying they're there, response or an invitation to feel grateful that the circumstances aren't worse. So what are some examples of non-empathic responses? I'm afraid you have pneumonia again. Patient's obviously upset. Quizzing and judging. Didn't you expect this to happen since you smoked for so long? Advice giving and placating. Just take all the antibiotics and you'll be fine. Placating alone. Well, don't worry. At least this pneumonia isn't as bad as it was last winter. And then finally, empathic. It must be upsetting and frightening to have this happen again after you worked so hard to stop smoking. So you're showing that you understand the stress that the patient is feeling because of the diagnosis. And, this is one of these topics where some people argue either you have it or you don't. But it is true that there are some basics of empathic statements that actually can be learned. So empathy for dummies. What does a basic empathy formula look like? If you get stuck and can't formulate a sophisticated response, you can always fall back on this simple idea. First, you want to identify the emotion. Mad, sad, glad, or scared. Don't use an intellectual word, so this is about responding to emotion. Second, identify the degree of the emotion. Is it a lot? Is it a little bit? So, for example, sounds like or looks like you are, modifier word, and emotion. Seems too simple, but it actually works. Sounds like you are really worried. So a lot of worry about this test result. Sounds like you're really worried about this test result. That alone can be very helpful as you apply this basic empathy formula. So after an effective empathic response, what happens is patients tend to lower the emotional tone, and they'll often say, that's exactly how I feel. Or they'll rephrase it to you, and they'll say, well, you're not completely on target. But they'll happily correct you because they still feel like they were heard. And listen really carefully after sending a response. So what the patient says directly afterward is very important information. It usually explains their emotional reaction. So for example, sounds like you're really worried about this test result. Absolutely. I'm scared a bad test result could mean I have cancer. So that reveals to you where their emotional locus is and gives you a sense of what else you might need to address in terms of how they're feeling about the topic that you're discussing. Now, what to do about anger responses is a little different, and we'll talk about that. So in terms of communication skills review, there's meta-communication. It's sort of your overall posture and all the nonverbal components of how you're relating to the patient that they often pick up on. Active listening, appropriate questioning using open and close-ended questions, responding and reflecting and using clarification for them, and then applying basic empathy so that they feel like they're being heard and that you care. And then we'll go into the Macy model of communication. So these strategies I'm giving you are sort of the glue, and the Macy model itself is the process. It's the step-by-step that we apply in terms of creating a good therapeutic encounter. This probably feels obvious to you and relatively straightforward. Believe it or not, this is well validated in the literature, and it's what is suggested as the approach for establishing good communication through a process of the relationship itself. So we start with preparing for the patient. We then greet and open, inviting them into the consultation room. We begin gathering information and also eliciting and understand the patient's perspective on their conditional state. And we also recommend communicating during the exam itself. And once we begin to develop a plan, we go into the process of patient education, but then we negotiate and agree on a plan. And that's a really important feature of this because oftentimes we give the patient a plan, but we have a missing piece, and that is how likely is the patient to adopt the plan that you're offering. And I'll show you some strategies on how to do that. And then finally, we close. So the fundamental skills to maintain during the entire interview, we use relationship building skills. We want to allow the patient to express themselves, be attentive and empathic, use appropriate language, communicate non-judgmentally, respectfully, and supportive attitude, accurately recognize emotions and feelings. We also use PEARL statements: partnership, empathy, apology, respect, legitimation, and support. And then we respond to those appropriately. And then finally, we want to manage the flow, be organized and logical, and also manage the time effectively of the interview. So as we go through the process of the Macy model, we begin the interview by first preparing. So you're reviewing the patient's chart. You're getting in your head the types of topics and pieces of information that you want to cover, maybe more that you want to know, and have a game plan. I think that's really important as you begin to orient yourself. And this also includes making sure that the physical environment is comfortable, avoiding interruptions and distractions. And this is the time that you want to assess what are you bringing into the room, your values and biases and assumptions, what's your emotional tone, how are you feeling that day, because patients will pick up on it. So then with the opening, of course, I think this is kind of part and parcel to integrative medicine. You want to greet the patients warmly. If this is the first time, of course, you introduce yourself and also begin to explain role and orient the patient to the flow of the visit and indicate the time available and other constraints and minimize barriers to communication. And also quickly try and assess how you're going to calibrate your language to the patient so that they can really understand what you're talking about and then accommodate them for comfort and privacy. As we get into what we consider the meat of the process, which is gathering information, this is where all the questions and exchange occurs. So I'm going to survey the patient's reasons for the visit. We typically start with open-ended questions. I usually say, what brings you in today? How can I help you? And if the patient says, well, I don't really know where to start. And I often say, I want you to begin where you feel it's most important. And this could be years ago as a lead up to why you're here today. And that's okay. We could even begin with your birth if that makes the most sense to you. But I want to hear your story. It's best to do it chronologically. And this sort of storytelling, this is what we call narrative medicine, is very powerful. And you have to let the patients talk without interruption. Use your active listening skills. Give that sense of empathy. And even though if the patient is not always focused and coordinated, it's important to ask what they think their chief concern is. And this could be closed-ended questions that are non-leading, and then also complete your review of systems to elicit their lengthy set of symptoms, and then you want to complete out their medical database. So once you get through that process, we want to make sure that we elicit and understand the patient's perspective on what they talked about. And that means asking patients about ideas, about illness or problems. Why do you think you're so sick? Why do you think you haven't gotten better despite the fact that you've tried so many different practitioners and therapies? What are your expectations in this process? What are you trying to get out of seeing me as a practitioner and coming to this clinic in general? What are your beliefs and concerns and expectations? What about support for you, your family, your community, your religious or spiritual context? What brings meaning and purpose to your life? How does that fit in to how you feel and your illness today? You want to acknowledge and respond to patients' concerns, feelings, and nonverbal cues, as well as their frustrations, challenges, and progress that they're making or maybe not making. You also want to attempt to communicate with them throughout the physical exam. If you do a physical exam, I do in my own practice. I think that's important for me as a trained family physician. So we prepare the patient, we consider commenting on aspects and findings of the physical exam. I also talk to them more broadly about what's going on with them. I find that this time of physical interaction can be very therapeutic for them, and sometimes we can even elicit more information this way as you do your physical exam. You also want to listen for previously unexpressed data about the patient's illness or concern. Some patients, it's during this process in particular that they start to lower their emotional tone. They see that you're touching them in a professional, therapeutic way, gathering continued information, and they start to reveal even more about what's going on with them. Once you've gone through that process and you begin to formulate an idea of not only what's going on with the patient, but you want to develop and deliver an action plan. This is the time that you begin to employ the ask, tell, ask approach to giving information meaningfully. So ask about knowledge, feelings, emotions, reactions, beliefs, and expectations. We tell the information clearly and concisely in small chunks. You want to avoid quote-unquote doctor babble and ask repeatedly for patients' understanding at different phases of the process. You want to use language that they can understand, qualitative data accurately to enhance understanding as well, and use aids to enhance understanding. So if you have any diagrams or models or printed material that's at your disposal, I think that can be really helpful for patients. And of course, finally, encourage questions. Now, this phase is key. Negotiate and agree on a plan. So I think a lot of practitioners believe they're done with the process when they deliver the action plan. And they say, I want you to do X, Y, and Z. Here's your diet. Here's your exercise regimen. Here's your stress management techniques. Here's your dietary supplements. Here's your hormone regimen. These are the peptides I want you to take. Here's the other practitioners I want you to interface with. Here's labs that I want you to do. And I want you to follow up with my health coach in 6 weeks, my nutritionist in 8 weeks, and me in 10 weeks. Okay? And the patient automatically starts to feel overwhelmed. But if we don't check in with them, if we don't negotiate with them around this plan, you'll never know if they're really willing to follow through, and we'll never know the extent to which they could be successful or not until the next visit. And you don't want to do that. You want to really come up with a mutually agreeable plan that they can implement, that they feel empowered, there's a sense of self-efficacy. And we want to check patients' willingness and ability to follow through on the plan. And we can do this using very specific strategies that I'll talk about in a little while. And then we end the interview process, meaning we signal closure, we carve out any final issues or concerns, allow opportunity for final disclosures. We know this has happened when you have your hand on the door handle, and then the patient says, oh, one more thing. It always happens. So you want to make sure before you get to that moment and you're out the door, you've already given the patient a moment or two to say, is there anything else that I need to know that we haven't discussed? And then we want to clarify future expectations and assure a plan for unexpected outcomes and follow-up, and thank the patient and reschedule. So this is the Macy model. This might feel very straightforward, something that you probably do naturally, but this is grounded in the evidence. This is the process that's been well-defined. At the core of this, we use a variety of what we call Pearl statements, which I mentioned before. And this is meant to elicit feelings and emotions and reaction description about how the patient is doing, how they're reacting to the discussion that you're having. For example, what's your reaction to this? How are you feeling about this? You look worried. You also want to ask about beliefs, meanings. So ask about why he, she has the problem and what it means to them. And then also expectations. So ask about expectations of future outcomes. What do you expect to happen in the future? So what are these Pearl statements? Again, they're allow us to recognize patients' emotions, and they show that you've noticed by responding actively. So the P stands for partnership. The function is for joint problem solving. Statements such as, let's tackle this together. Empathy. The function is to show understanding. We've talked about this. Put feelings into words. Show compassion about the illness. Statements such as, that sounds hard. You look upset. You seem discouraged. I'm sorry you're ill. Apology. The function is to show concern for errors and hurt. Statements, I'm sorry you're hurt, offended, they or he or she or I upset you. Or even here's one, I'm sorry you're ill. So these start to blend together a little bit. Respect. The function, value patient's choices, traits, behaviors, and special qualities. Statements. I appreciate and respect your courage, decision, action. You've worked hard on this. I can see that. I'm really proud of you. I'm glad that you've applied yourself to this, and I'm impressed by all the work that you've done to try and do better and feel better. Legitimation. Function, let the patient know that his or her response is normal and expected. It validates his or her feelings and choices. What are some statements? Anyone could be confused, sad, irritated by the situation, or I can understand why you feel this way. Support. The function, offer ongoing support, non-abandonment. This is important. Usually you're the provider of last resort. So I think it's important that patients know that you're there to support them. Quote, I'll stick with you as long as necessary. We'll work on this together. I'll be there for you. You want to resist the powerful temptation to pursue clinical details when responding to emotion. That this is about you supporting them as a whole person. It's not just about solving a problem. So what are some advanced communication strategies? Well, there's always times that we have to break bad news. This is not always easy. In addition to that, negotiation and managing conflict. I think a lot of us don't like conflict, but this sometimes comes up with patients. We also want to learn to communicate for behavioral change, state of readiness, motivational interviewing techniques, adherence, and negotiating an effective treatment plan. So once you know what the plan is, usually it requires effort on the patient's part. So how do we engage the patient behaviorally speaking and sustain that behavior over time? And then finally, difficult patient-physician interaction. So what is bad news? Well, any information that will adversely change the patient's view of his or her future. What the patient perceives as bad may not be how we perceive it. And it even can be often surprising to the patient and often elicit strong emotional response from the patient and from the care provider. So breaking bad news. We know it's stressful for us as practitioners. We worry about these stressful responses. And some of us have a lot of inexperience with breaking bad news. It can be tiring as a process, and the seriousness of the news also can influence how much stress we feel as a provider. And it directly, of course, contributes to poor performance and stress and burnout. So why is this so hard? Well, we're human too. We don't want to hurt our patients or take away hope. It's unpleasant, and we worry about the patient's response to this. We often feel like we have to do this in the middle of a busy clinic, and we have concern for not only the patient's reaction, but also the family's reaction. And in addition to that, we're not always sure how to handle that response, especially if it's very strong. We may feel guilty about the failure of treatment or afraid that you'll be blamed, that if there's some poor outcome, even if it wasn't something that you did or didn't do, that as the patient's illness gets worse, and there might be a definitive problem that occurs that we have great concern about, we think we'll be blamed. And so learning basic communication skills can help, and the best way to help the patient is to deliver the news well and compassionately. And we do this by identifying and dealing with our issues so that we can focus on the patient. and even consider a debrief after seeing the patient with coworkers or colleagues in your practice. So what are the styles that people deploy for breaking bad news? There's the blunt style. About 37% of practitioners use this style. They just deliver the news right away within 30 seconds. There's really no attempt to place news in context. We just talk about the issue. There's the forecasting style. About 45% of practitioners utilize this. So they deliver news within the first 30 to 120 seconds, initially place news in context, and provides news to allow understanding without jargon, details given later in the interaction. And then there's finally the stalling style. This is the most uncommon. Deliver the news after 2 minutes of interaction. We use lots of euphemisms, and sometimes patients even have to guess what's going on. So what are some essentials for how do we break bad news? Well, it should be one person that should be responsible for the process. Recognizing the patient has a legal and moral right to accurate and reliable information. The clinician's primary responsibility is to the individual patient. You want to avoid conspiracies of silence, and that means we need to ensure that the patient understands their treatment options and reasons for any future investigation. We also need to tell the patient the diagnosis as soon as it's certain. You can't hold back. When those results come in on a scan or blood results, we really should call the patient right away and inform them what's going on. But don't do it over the phone. You want to call them into the clinic and talk to them about what's happening with them. You also want to make sure you make every effort for privacy, use good eye contact and body language to convey warmth, sympathy, encouragement, or reassurance to the patient. There is a process to this too. Just like we have the Macy model and Pearl statements, we can also use the acronym SPIKES, which stands for one of the most popular strategies for breaking bad news. And remember, you cannot impart this information until the emotional tone is acknowledged and addressed. So how do we do that? Empathy and active listening. And then we go into these strategies. So S stands for setting up. You arrange for privacy. P is perception of a condition or seriousness. Explain to me what you understand of your recent diagnosis. So this is listening to the patient's level of comprehension. Accept denial, but do not confront at this stage. The I is invitation from the patient to give information. Ask the patient if they wish to know more details. Sometimes they don't. Sometimes they sort of reach a limit and say, okay, you've told me enough for now. So would you like me to explain exactly what your diagnosis means? Knowledge, giving medical facts. You want to use intelligible language. At the level of the patient, make sure that they understand what you're saying. Quote, when we examine your chest x-ray, we saw a small visible mass. This is usually an indication of cancer. Is this all making sense to you? At that point, especially when they hear the word cancer, they tend to feel immediately overwhelmed. And so you want to do a check-in. Does this make sense to you? E, explore emotions and sympathize. So prepare to give an empathic response. Identify emotions expressed by the patient. We've given you some tools for that. Has your diagnosis come as a shock to you? Explain to me how you're feeling right now. So you're doing an emotional inquiry of the patient. It's not about the diagnosis of cancer. It's how do you feel in this moment? And that check-in, again, is really important. And then strategy and summary. We close the interview, want to clarify if they need to go further in some ways, offer an agenda for the next meeting. Has this all made sense to you? Have you any more questions? When do you wish to arrange our next meeting? So communicating for behavior change, state of readiness, and motivational interviewing. So motivational interviewing is a well-defined method of communication that helps to facilitate and engage intrinsic motivation within the client to change behavior. So this is all about once they've gathered knowledge and they have the sort of desire to make a change in their lives, we need to give them tools and support those behavioral decisions on a day-to-day basis. So this is very goal-oriented. It's patient-centered. It's a type of counseling, essentially, that we want to elicit behaviors to help patients explore and resolve ambivalence, basically raise a therapeutic paradox for the patient. In resolving the paradox, you help them discover their own motivation to make the change. And then I've included a link to a video in that regard. So how do we do this? Again, another acronym called OARS. These are key skills for motivational interviewing. Again, we start with open-ended questions. We want to then affirm and highlight any positive aspects to create a sense of empowerment. You can also use this stuff to acknowledge the positive aspects of their current situation. You said smoking is relaxing, that you're under a lot of stress now. I know that seemed like the best choice to you at the time. And then we want to reflect to the patient, to reflect back the thrust in their thinking, especially if there's some sort of conflict. I love smoking, it relaxes me, but I know that I need to make a change. You can understand implicitly now why there's a paradox here, almost always, because there's a set of habits and behaviors that they often rely on in their daily life, and you're asking them to make small changes in a new direction. And so we want to be able to summarize that very clearly with them and give them good reasons for change that they come up with. So we reflect back. So you want them to engage in the process and identify what are their reasons to change. So how do we resolve conflict with patients? Well, this is really important because not every patient is easy to deal with. And there's a scale that's typically used to determine where do we fall on the spectrum when there is conflict with patients. So some of us are more assertive, and we just basically say, look, this is what I want you to do, but you can end up in a power struggle with patients if it's not what they want to do. And then conversely, we can end up being very cooperative with patients, but a little wishy-washy. So some of us just kind of avoid making decisions with patients, and we're almost too accommodating for them, so we can exceed power to the other party, meaning, we always have those patients who they're asserting themselves and we're accommodating to the point where you feel like you just want to turn over the prescription pad and they can order the test and decide what the therapy is because they kind of want to push you out of the process. So we want to move in the other direction where we begin to blend the best of these areas, so we collaborate. And that is to say, we have a discussion, we employ an approach that ensures that the patient is engaged, they feel understood and heard, but you also give your expertise, and within a set of choices and decisions, you together come up with a plan that makes sense. And a lot of this, again, relies on our style of communication. Much of us as experts, we tend to be very biomedical. We want to have the answers, and we essentially tell patients what to do. And unfortunately, 70% of us, this is how we operate. But we want to be more patient-centered. A high level of collaboration. This is the psychosocial model where we spend time with the patient determining what's in their best interest. And all of this is to ensure we have a high level of adherence by the patient to the plan. So what is non-adherence? And why do we use this instead of maybe the word non-compliance? So non-compliance is an older term. Well, for me, a non-adherence is more neutral, and non-compliance assumes that the advice of the healthcare practitioner it reflects who's in charge. And so we want to avoid triggering patient defensiveness when asking about adherence. For example, have you been taking the medicine versus did you finish all the medicine? What happened when you started to exercise versus how far did you get at the gym? So patients are more likely to hear if they feel that the treatment is directed towards them and it's not a one-size-fits-all model. And there are lots of reasons why patients may have trouble adhering to the plan. It could be for demographic reasons, sociocultural, behavioral. There can also be external factors. Just the disease process itself can get in the way of them sort of following through and being consistent. They can have problems with the medications or supplements. And then finally, the system itself, access to care and health insurance and their financial situation, all of which contribute. And also us as providers. How good are we communicating? Do we establish positive relationships with patients? And are we in concordance with them based on their demographic factors, meaning ethnic, racial, cultural, so on and so forth. So all of these things may either contribute to positive adherence or non-adherence. And so what are some of the strategies for improving adherence? Well, good education, of course, is key. Engaging the patient in a social network, so we ask them to find people who can support them in the process. Sometimes we can begin to deploy reminders for them to make sure that they're staying on track. We also need to improve provider communication so that we can elicit positive patient interactions and improve communication skills. We also want to work on simplifying regimens, especially if they're too complicated. There are mechanisms now for auto delivery of certain therapies, such as supplements, for example. EMRs can also help in terms of consistent prescribing. And then team-based care, we have that in my own practice, where I have my nurse practitioner, my health coach, my dietitian, all wrapping around the patient to ensure success. So how do we employ persuasion? And these are some components to consider. So this might feel a little more authoritarian in that regard, but it's important to recognize you do have lots of power in this relationship. We're very potent. So what authorities do you trust and why? How do you demonstrate your authority in patient relationships? You know, we can be much more assertive, as I've mentioned before, as opposed to collaborative. We sometimes want to do this to ensure consistency, to engage patients, to say, look, this is a plan that I think will be successful for you, but I need you to be consistent. We can make small changes over time, but I need you to engage in that process. And also likability. So this notion that empathy is one way to show the patient that you understand their circumstances. And patients are more likely to adhere if they feel that you do care about them and that you're really present when you're speaking to them in the context of the patient encounter. You also want to be cautious about sharing personal information. I know practitioners who freely do that. They discuss their own health challenges and personal issues. But depending on the sensibility of the patient, there are sometimes boundaries that you have to draw in that regard, and we want to be careful. And then finally, consensus. Note the importance of the personal influence and that you come to a collaborative conclusion. Now, I think this is really important. This gets back to the Macy model of negotiating the plan for success. We want to be collaborative, as I mentioned. We want to choose reasonable goals, make small changes over periods of time that are consistent. And we want to write the plan down, or even better, have the patient write the plan down. Now, as you're laying out the plan, I always have the patient rank each one of the features of the plan on a scale of 0 to 10. 0, no way am I going to do this. 10, no big deal. So the question is, how likely are you to carry through with the changes that we've discussed today? This is an incredibly powerful tool. And you will be surprised at how many times there are 3s and 4s in addition to what those 3s and 4s are, as opposed to an 8 or higher. We want to see 8. And we have to renegotiate the plan if there aren't 8. If their response is less than 8, we need to decide, well, what are those barriers? And how do we help patients supersede those barriers? And sometimes it's altering the plan fundamentally, removing certain aspects of the plan, or changing things so that we can create smaller goals so everything is an 8 to a 10. So the difficult patient. It's okay if you disagree with my diagnosis. I can prescribe something to make you less agreeable. This prescription won't make you feel better, but it will stop your whining and make everyone else feel better. And then finally, the difficult medical system, which of course we all complain about. Age, you mean now or when we first sat down? Funny, I thought the hour-long wait was the stress test. And then finally, the doctor will see you now. Here's your medical jargon dictionary. So, what have we talked about? Well, we need to address the provider component. So you need to be aware of yourself. How are you feeling? Do you feel stressed? Have you been triggered some way by a particular patient? Do you have any uncertainty in terms of what you're doing? Are you avoiding conflict when you need to address it? Are you feeling defensive or manipulated by a patient? You want to ask questions before you tell the patient, quote, what the truth is. Make sure they feel heard accurately as well. Be compassionate but firm, especially when setting limits, and use I language. For example, I know that you feel that a narcotic is the only thing that will work for you, but I don't feel comfortable prescribing one for you. I have other options to offer. Would you like to talk about those treatments? So this personalizing it, using I statements, setting boundaries, being compassionate, and checking into how you're feeling can help you deal with some of these difficult interactions. You want to use the techniques of reflection, clarification, intent to body language to show the patient that you're engaged and sincere. And using those empathic techniques allows you to show the patient that you've understood their position from their perspective. And this will allow you to diffuse many difficult situations because you want to lower the emotional tone and let the patient really talk about what's their true concerns. So in summary, we talked about self-awareness, which I think is central to this process. Basically, mindfulness, because mindfulness and enhanced awareness is what allows us to be present, to calm ourselves, calm the internal discord, be present for the patient, and show them that you are there for them and that you're willing to collaborate and come to a set of ideas and plans that they can achieve and feel empowered by. And that means having a healing presence, active listening, demonstrating empathy, developing good communication skills with a focus on positive collaboration, good specific goal setting so that they can adhere and be successful over time, which will enhance their trust in you. And this is the full circle of how we enhance the therapeutic relationship. So key, and again, probably obvious to many of you, but I can't overstate the importance of why this is so important to not only improve patient outcomes, but decrease burnout and stress related to this style of practice, and ensure that you're lowering any potential legal risks, but most importantly, creating that therapeutic bond so that patients feel empowered, they have a heightened level of self-efficacy, and that all of this typically translates into better clinical outcomes. So thank you so much for listening to this important lecture on the therapeutic relationship and communication skills. Once again, I want to thank Da Vinci for offering this new series on professional education. I hope you enjoyed it and you took away some good clinical pearls and tools so that you can develop good relationships with your patients and you have positive interactions with them to improve your patient care. So thank you once again.